We should get started. Thank you for joining us today for the University of Washington eScience Data Science Seminar. The University of Washington acknowledges the Coast Salish people of this land, the land which touches the shared waters of all tribes and bands within the Suquamish, Tulalip, and Muckleshoot nations. Today's seminar features Dr. Afsaneh Doryab, Assistant Professor in the University of Virginia School of Engineering and Applied Science. Dr. Doryab works at the intersection of health, mobile, and ubiquitous computing, artificial intelligence, and human-computer interaction. For example, by modeling human behavior using data streams available from mobile, wearable, and embedded sensors. Examples of her research in the health domain include detection of behavior change in people with depression, estimation of symptom severity in cancer patients, and modeling of surgical activities inside the operating room. In addition, she develops tools in the social good space, including connecting communities of people through mobile technology to enable successful and meaningful service transactions, especially in low-income communities. From this description of her work, it isn't hard to see that she leverages machine learning, data mining, statistics, and human-computer interaction. Today, she will speak to us about computational modeling of human behavior for health and well-being, the exact title being modeling of human behavior from longitudinal data streams for health. As usual, I will encourage you to use the Q&A button to ask Dr. Doryab questions, and I would invite her to begin the presentation. Thank you.
Thank you so much, Nicoletta. Hello, everyone. As Nicoletta mentioned, I work in the intersection of health, machine learning, and passive sensing. So as we know, humans these days interact frequently and intensively with computing devices. And these data streams and these interactions generates a lot of data streams that offer clues about the physical and mental state of individuals. In my work, I develop techniques that enable the state of behavior for these individuals to be inferred from these data streams. So the three ingredients, essential ingredients of my work are passive sensing, longitudinal data collection, and behavior modeling with machine learning. I use these three ingredients to build models of behavior to detect and predict models for mental health, physical health, and social health. As Nicoletta mentioned, examples of my work include in mental health include forecasting mood in bipolar disorder, predicting depression and loneliness in college students, which I will be talking about in a bit, detecting sleep quality in physical health, modeling cyclic behavior, promoting healthy behavior, estimating symptom severity in cancer patients, and in social health, I use behavior modeling to detect, for example, implicit bias, friendship, and binge drinking. And in all these, I use mobile and wearable devices, and I collect data in the wild. So why smartphones are good candidates for behavior monitoring? As you know, most people own a smartphone. In fact, more than 83% of Americans own a smartphone, not a cell phone, a smartphone. People carry their phones with them wherever they go. They are unobtrusive, inexpensive, and offer a rich set of sensing channels for behavior tracking. You can track locations you go, movement patterns, physical activities, social communication, voice, web search, etc. So there are every time we use this mobile sensing and wearable sensing, we have to pay attention to some challenges that are associated with behavior modeling for health in the wild. I'm listing 3 challenges that we often face, and we basically need to address them, and I'm going to address them in this talk. The first one is determining the frequency of data collection. Longitudinal data collection requires lower user burden for longer engagement. We need to identify what are the most useful data sources, because smartphones and smartwatches have limited battery, and collecting a lot of data consumes a lot of battery. And we also need to find out what are the appropriate analytic methods are for this type of data, because we want to extract most value from this data, and we need to build lightweight models for deployment, again, for the same reason as small devices have limited resources, and we need to pay attention to that. So I'm going to talk about a recent study we have done to predict depression and loneliness. Specifically, I will focus on loneliness, but this was a cross-institution initiative for assessing health in college students involving several universities, Carnegie Mellon, University of Washington, Georgia Tech, Dartmouth, Cornell, UT Austin, and several European universities. The work was done at the time I was at Carnegie Mellon. We collected 2 rounds of semester-long data collection. Phase 1 was spring 2017, collected data from 138 first-year students. In phase 2, the next spring, we collected 200 data from 267 first and second-year students. And we provided all participants with Fitbit Flex 2 and also an aware data collection app, which was developed in our lab. So the passive sensing data we collected was Bluetooth call logs, including incoming, outgoing, missing calls, location coordinates in terms of GPS, and screen status, whether the screen is on, off, locked or unlocked. From Fitbit, we collected sleep and steps, and sleep data included whether the person was awake, asleep, and restless. And we collected this data for 16 weeks during the semester. Participants also filled out some self-reported measurements for depression, loneliness, and other health measures, self-worth, productivity, etc., sleep quality, and so on. And we use this data as the ground truths for our analysis. So I'm going to focus again on loneliness. We used the UCLA score or scale for assessing loneliness, which includes 20 questions about how lonely and isolated people might feel. The scores are from 20 to 80, and higher score means higher loneliness. We decided to do a classification for post-semester loneliness and change in loneliness. In post-semester would be, we would predict no to low loneliness, scores below 40 versus moderate to high loneliness, which were scores above 40. And for change in loneliness, we looked at increase, decrease, and unchanged loneliness. So we found that loneliness level in our participants was relatively high. Pre-semester mean score was 43.6, post-semester was 43.3, and the high loneliness in pre-semester was 63.8%, and at the end of the semester it was 58.8%. But this statistics is aligned with the nation's statistics that says young generation have the highest loneliness level among all the generations. So we wanted to build a machine learning pipeline for predicting different health outcomes here, loneliness or depression, for example. where we faced the first challenge, that we had a lot of continuous sensor data, but not much ground truth. As I mentioned, we only collected pre and post semester data. So even though we had a relatively large participant pool and a lot of sensor data, we still had one data point per participant. So, but that is the reality of the data collection, because ideally, for building a tool that works on the mobile phone and is able to track the mental health or mental state or physical health, whatever it is, we want to be independent of the user. We want to be able to detect their state of well-being without asking them questions, right? So we took this challenge. We also wanted to capture the student life over the semester as fine-grained as possible. So what we did was to try to extract higher level features from low-level sensors and from different temporal slices to capture hourly, daily, and weekly variations of behavior. Some features were simple statistical measures of sensor inputs, including mean, median, maximum standard deviation, but others were more complex, like circadian movement that indicated regularity in person's movement pattern. We identified different epochs, like daily epochs, morning, afternoon, evening, night, and all day. Just we segmented the day into these epochs, and weekdays, weekends, all week, and then half semester. So there were different levels of aggregation in feature extraction. So this left us with a lot of features, and over 50,000 features, and we had only 138 people. We had 7 feature sets, and each contained behavioral features calculated over 45 temporal slices. So as such, building a model that included all these features would almost be impossible. So what we did was to build a model per feature set. So from each sensor set, we built one machine learning model, and then combine the prediction probability from these models in another round of classification to obtain the final prediction label. So to train and validate the feature set models, we basically took these the features belonging to each feature set and did the feature selection inside cross-validation, did the modeling and did the model selection, and then chose the best performing model at the end to go to the next round. But even though we built a model per feature set, we still had a large number of features in each set. And so we further decomposed our feature space into time segments and performed a randomized logistic regression, which is a feature selection method for stable feature selection, which, like randomized logistic regression creates several subsamples of the training data set and computes the logistic regression on each subsample, and then selects features by optimizing their importance across the subsamples. And then the selected features from all groups were then grouped to a much smaller set of features. And we applied the randomized logistic regression again on that set to obtain the final stable features. And that's, we call this method nested randomized logistic regression. So that worked fine. And then in the next round, we, again, as I mentioned, we combined the prediction probabilities from all the sensor feature sets separately and run an ADA boost algorithm in another round of cross validation and to provide the final prediction. This step actually helped us with the third challenge that I mentioned, that to find out what data sources are most useful. So given that we built a model per feature set, we could both look at each feature set alone and in combination with other features and other sensors. So the results that we got, as shown, and they were compared to the baseline, which was the majority class, and most of them performed relatively well. And the best set we had outperformed with using all the features, or temporal features and fine-grained features that we had. We obtained accuracy of 80.2%. So the best set were call logs, location, campus map, and phone usage, sleep, and steps. And campus map was the specific locations on campus that we extracted from location further. But in change in loneliness, we saw that all features did not perform that well. And in contrast, the semester-only features were the aggregated level. On the semester level, they performed better in detecting change in loneliness with 88.4% accuracy. And the best set was Bluetooth, combination of Bluetooth, location, screen, and steps. So this was good, but we had further questions. So we wanted to know how these select features, behavioral features, relate to loneliness level. So this is the question we often are asked by our colleagues, clinicians who we collaborate with. They want to know how they relate to these different health outcomes, the behavioral features we extract from mobile and wearable devices. So we took an innovative approach, applied a priori, which is a well-known frequent item set algorithm for discovering associations among items in transactional data sets. And we extracted combined behavioral patterns that were most associated with the level of loneliness. So I'm sure you know how a priori works, but I am just briefly describe what it does. It generates a set of frequent items that appear together, and then extracts association rules that explain the relationship between those frequent items. So the extracted rules must satisfy a degree of support and confidence in the dataset. Where support is the percentage of transactions that contain both X and Y, and the confidence is the percentage of transactions that contain X that also contain Y. There's another measure, lift, which we did not use in this study. So we use a priori to extract combined behavioral patterns that were most associated with loneliness. So this is what we got, and this is the best way we could describe it. So as you see, there are a lot of patterns and a lot of combination of patterns, which we could not get with other correlation-based or anything else that looks at the behavioral patterns. So that was good, but so it looks a little messy, but all it showed was the gist of it was that the frequency and timing of phone usage combined with spending less time off campus and at social event houses during evening hours on weekends were most indicative of high loneliness in college students. So yeah, so as you see, this is a very, like a combined, and it's a very fine grain and the details of when, where, and how that pattern is observed. So the other pattern was lower phone usage and less activity after midnight were associated with a decrease in loneliness at the end of the semester. So Going back to the challenges that I mentioned, one of the important ones was determining the frequency of data collection to have lower user burden and for longer engagement. So it is important to decrease the amount of requirements that we have for the users. You know, like for example, for loneliness, we ask 20 questions, right? It was fine in our study that we had only we only asked them once pre-semester and once post-semester. But if we wanted to collect, to ask users about how lonely they feel more frequently during the semester, 20 questions would be a lot, right? So we were curious to know whether we could find a smaller and shorter set of questions about loneliness we could ask that were that we could use instead of asking 20 questions. So we ran we extracted associations between ratings of UCLA questions and the level of loneliness, and we found three questions that appeared in both pre-survey and post-survey, with, in fact, the feeling of isolation question appeared in both pre-survey and post-survey, having a higher support and confidence. So we were curious to know whether the behavior patterns that are extracted from passive sensing would tell us anything about loneliness level the same way as we did in the previous step. Again, it looks messy, but the gist of it is that students with low feelings of isolation spend less time studying in the afternoon and weekends and spend a moderate amount of time in green areas in the morning. And patterns of social activity and steps during the day and evening hours, as well as timing of the phone usage, were associated with decrease in the feeling of isolation. So we did not read too much into it, but it's definitely something interesting that when we have more data, we would want to look at this. This is definitely the behavior patterns are something that is interesting to the clinicians and also us as researchers. So related to these behavior patterns, I've recently become curious about or interested in modeling cyclic behavior or human rhythms. So this is basically using passive sensing data to model biobehavioral rhythms. This is an NSF grant that, and my co-PI actually is Anende, who is the Dean of Information School at the University of Washington. So biobehavioral rhythms are repeated cycles of physiological, psychological, and environmental events in people's lives. And so some of the cycles are known, like sleep activity or circadian rhythm that has a 24-hour cycle. So biobehavioral rhythms are associated with numerous health and life outcomes. And given that it is possible to collect biobehavioral data through mobile technology in the wild, our question was, can we detect and model rhythmicity in human behavior through longitudinal passive sensing? And if we can, are rhythms useful in predicting health outcomes? So we explored modeling biobehavioral rhythms using data from cancer patients to predict readmission risk after surgery. So readmission risk in cancer patients is high. Almost a third of them are readmitted back to the hospital within 60 days after discharge. And circadian dysregulation is related to poor health outcome. So we wanted to test whether this circadian disruption can or how well the circadian disruption can predict readmission risk in cancer patients. So we analyzed Fitbit and smartphone sensor data from 49 patients undergoing abdominal cancer surgery. We modeled individual biobehavioral rhythms before surgery in hospital and 60 days after discharge. And we use the features that we obtained from those rhythm models in a machine learning pipeline to predict the readmission risk. So we first modeled rhythmicity. We ran some cyclic methods, cosine modeling, autocorrelation, periodicity detection on activity and heart rate data. We identified circadian disruptions before surgery in all 3 stages, before surgery, in hospital, and after discharge. And we observed significant differences in rhythms within and between patients across those 3 stages. So this is the autocorrelation or activity correlogram. So autocorrelation calculates the correlation coefficient by comparing the time series data to itself from start to end. In each round, the 2 time series are shifted by 1 point, and the process is repeated until 1/3 of data is processed. If the data is rhythmic, the R values increase and decrease in regular intervals. And repeated peaks above the confidence interval, which is the blue line, indicates strong periodicity in the data, and rapid decay in the amplitude of peaks shows variation between cycles in the data. So we see regularity in both patients in before surgery, but it is decreased as they get to the hospitalization. And at the end, when after discharge, the non-readmitted patient goes back to normal, but this pattern is not observed in the readmitted patient. We also build a population cosigner from the groups of the non-readmitted patients and readmitted patients to compare their behavior, rhythmic behavior, cyclic behavior. And so on the left is non-readmitted patients. Excuse me. So the black line shows the raw data, and blue line shows the cosigner model. And the x-axis is the hours before surgery. The y-axis is the level of activity. So both groups, both non-readmitted and readmitted patients, had relatively regular cycles before surgery. In hospital, both groups experience irregularity. After discharge, the non-readmitted patients pretty much went back to normal, but this wasn't the case in the readmitted patients. So we observed circadian disruptions in all patients. Majority of the patients had 24 hours activity rhythms before surgery and after discharge. Most patients had disrupted rhythms in hospital, and none of the readmitted patients had a 24 hours rhythm in hospital. So this was an early indication that the in-hospital data might be predictive of readmission risk. So we then use the rhythmic features in a machine learning pipeline to predict readmission. So the features that we extracted included the amplitude, measure, period, and acrophase. We also extracted other features, including the mean of diurnal activity, nocturnal activity, intraday stability, intraday variability, most and least active hours, circadian variance, and total sleep time and efficiency. We then used boosted logistic regression with an ensemble of linear regression and decision stump as base learner. And we used leave one patient out cross-validation. So for comparison between our models and baseline, we use 2 measures that are used in hospitals currently, LACE and hospital. They're based on patient status and medical history at the time of discharge. All 3 models we built before surgery in hospital and after discharge outperformed the current baselines, especially in hospital. Data appear to perform best and showing that 6 out of 10 readmitted patients could be identified accurately. So what we learned from this was that, and we learned and confirmed that biobehavioral rhythms can be detected from commercially available wearable devices. And rhythm-based features can predict health outcomes, here readmission risk. And on the clinical side, we also confirmed that hospitalization disrupts circadian rhythms, and circadian disruption predicts readmission risk. So in ongoing and future work, we basically are now trying to apply this modeling of rhythms on the data set that I just talked about in loneliness in college students. And we're trying to understand the impact of their mental health, the impact of circadian disruption, rhythm disruption on mental health and performance. And so we're also planning studies to collect longer term data that are more than a year, because that is basically what we need to understand longer term rhythms that have longer cycles than, like a month, 6 months, a year. That requires a longer term data. So with that, I guess I'm pretty early, but that's basically what I wanted to talk to you about today. And with this, I conclude my talk, and thank you for listening.
Well, thank you very much. That was really great. Please use the Q&A button to ask questions. In the meantime, I think I'm just curious about like how to use the data to, improve, the state of loneliness. I was just actually curious, for example, in your first example, like you talk about young people having high levels of loneliness. Has that been historically proven, or is this something new? And what can we do with these models to, improve this situation, if that's possible?
Yes, that's a great question. But it has been. So it's basically our data, our scores are not that different from the national statistics. So in fact, they are pretty much pretty close. So I believe most of the young adults, or Generation Z, they call them, they have high level of loneliness above 43. So yeah, so this is pretty usual. And now, I mean, the reason I talked actually today about loneliness is because of pandemic situation. Like it made the situation a lot worse, and with people being isolated and so on. And unfortunately, exactly today, I heard from one of my colleagues that one of the students in this university, they committed suicide because of this exactly pressure from social isolation and the pressure from studies and so on. So, which is very unfortunate. But yeah, I thought it was a timely topic to talk about, because it is loneliness and social isolation has become the second epidemic in the United States. So, sorry.
No, go ahead.
I see a question. Should I read it or?
Yeah, I was about to say that that's really unfortunate, and maybe read out the question from the Q&A. Separate feature sets approach. Was feature interaction among features in different feature sets not modeled at all?
I'm not sure what you mean by feature interaction in different feature sets. So the feature sets were different. So each sensor was a different feature set. So as a result, the features were different. They did not interact they did not interact directly with each other. So like, for example, call features are separate, Bluetooth features, then what's called sleep features, step features, and so on. So I don't know, like if there is anything further, please add more. I'm not sure what you mean by feature interaction.
Thank you. I have a question from Dave. The question is, was it difficult to consent the university students to get the consent from the students given the amount of data you were collecting?
That's a great question because yeah, so we had to go through the IRB, an institutional review board. Always when we do human subject studies, we have to. So they come back and ask a lot of questions about to make sure that the privacy of the participants is preserved and is secure and so on. We have got used to it. It's not easy. Always, it's very time consuming, but we managed to do that. Yeah. So without IRB, we are not able to collect any data. We are not allowed to collect data. Thank you for questions. Yeah.
Yeah, I see in the chat that it was difficult. Yes,
yeah.
Everybody agrees it's really difficult. Maybe we can talk a little bit about your second example. Like everybody maybe knows that when people are not so well, they don't sleep well, the circadian rhythm is disrupted and so on.
Yeah.
And that shows in the data and the results you got.
Right. So it is, I think, somewhat intuitive. We probably expect that, but there is no studies that has actually shown that using the passive sensing, at least on all three stages. So there has been studies that shown, okay, so the circadian rhythms is disrupted in hospital, but it wasn't before surgery, after discharge. There hasn't been any studies, and I'm not aware of any other studies yet that actually have done that. So that was the unique aspect of the data that we had. We tracked patients before they went to surgery and while they were in hospital, and also 60 days after discharge. So we had good data, but it confirmed that in hospital situation is pretty disturbing. So partially because patients are not home, their routines are disrupted and all these things, and partially because they're in pain potentially and as a result of after surgery. So there are different things, but just seeing that we can actually predict. So we can see that the circadian rhythm is disrupted, but we didn't have any studies that actually use the circadian disruption and the features using machine learning to predict readmission risk. So that is also partially what was unique about our study. Yeah. I don't know if I'm answering, if I answered your question.
No, I totally, I think it just shows how risky it is or how bad it is. Put a number on the situation.
Yeah.
I don't see any, okay.
So
yeah, there's another question from Forrest. Regarding the loneliness study, can you talk a little bit more about the models developed to make prediction from the individual sensor data? Before integration through the Adibus.
Right, sure. I don't know, like if there, if the question is about this or the results. So this one again, this is what each model was built per sensor for using the features that we extracted from each sensor input. And the reason for doing that was because as I said, we ended up with a lot of features that we extracted from these sensor inputs. So even when we basically extracted, even when we built one sensor models, we still had a lot of features. So we had to further reduce the number of features in order to be able to build stable models. So that's why we did this nested randomized logistic regression, where we further grouped based on time or epochs that we had. Like, remember in the previous stage, it was these epochs, these temporal time slices. So we further grouped each set into morning, afternoon, evening, night separately, ran feature selection on each of them, and then again, so the most selected features were selected and grouped into a smaller set, including all the features selected from each epoch. And then we ran the logistic regression again to get a stable set of features. So this part was actually quite time consuming, and it took us a lot of time because we tried many different approaches, and we couldn't get good results. So we basically developed this model, this method we call nested randomized logistic regression. And then the selected features were entered into two algorithms, gradient boosting and then logistic regression. And then we took a voting to select the model that performed best. And that predictions for the output for all the participants were entered in the next stage for to go into the ADA boost. So I hope that answered the question. This is a question: would you expect the best fit model for high loneliness and change in loneliness to have different feature combinations for predicting loneliness during the COVID-19 pandemic? Oh, that's a great question. I don't know, but so obviously we would love to have that. So we would love to generalize this model to any other data set. But this is the only study that we have, and we haven't replicated it. So I don't know if it performs the same on the separate data set or will be the same. Obviously, there would be some data would be useless. For example, the campus data and location data, because people are not that active. Also Bluetooth, pretty much, because when you're isolated at home, I mean, these data don't say much, and they're not that useful. But I think still phone usage and sleep and steps to some degree, they say a lot about loneliness status. So I would say there are three best sensors are in this best set. So, and I expect that they would probably call logs as well. So they would still contribute to the prediction. If that is
Yeah, that was a really interesting question. And I'm actually wondering now if you are planning to do a follow-up during the COVID era.
Yes, yeah.
Okay.
In fact, actually, one of my colleagues at the University of Pittsburgh, Carissa Lowe, she has collected the long-term data, I think around 6 months of data, at least they have collected during COVID. And so we are, yes, and we are looking forward to basically analyze this data and see what we get. Obviously, I expect that the loneliness level would be a lot higher, and or reported loneliness level would be a lot higher as people experience more social isolation. Yeah, great question.
Yeah. Well, I don't see any other questions. So I think I'm just gonna thank you very much for your participation today in our data science seminar.
Thank you. Thanks for inviting me.
Looking forward to seeing more results from your research.
Thank you.
Yeah,
Thank you so much.
Yeah, you can find the recording on our YouTube channel and more from Dr. Doryab later. Thank you.
Thank you.
Have a nice evening. Bye. See you next week.
Bye.